Okay, welcome Slim Slama. So with me I have Slim Slama from WHO, and we are here in EASL headquarters in Geneva. And we just held an event in parallel with the World Health Assembly. And then we've been so fortunate that we can ask a highest level WHO person different things. So maybe first, could you tell me what's your title and what you're actually doing in WHO? I think that would interest many doctors.
Thank you, Aleksander, and thank you first for receiving us and giving us the opportunity to contribute to this important event. So, my name is Slim Slama. I'm the unit head of one of the 4 units of the Department of Non-Communicable Disease here in headquarters. So the unit is focusing on screening management, so it's really the healthcare component of NCD. And we have quite a large portfolio because we cover what we call domain non-communicable disease, cardiovascular disease, first cause of death, but also cancer, diabetes, chronic respiratory disease, oral health, but also NCDs in humanitarian settings and emergency, and some aspect of digital health solution applied for NCD management.
Oh, that sounds super exciting. But I know you're a specialist in internal medicine and practice medicine for many years here in Geneva. Can I ask you a personal question? So what urged you to join WHO, and what's the most exciting thing of working for WHO?
Yeah, it's quite a long story, but to cut it short, I mean, first, I think we don't choose to be an internal medicine specialist by chance. I was very much interested by the holistic approach of health, the psychosocial dimension of it, but also the complexity of problems that are intertwined. And we have one body with multiple facets, and disease are interrelated. So I wanted from the start to understand things in their complexity, in their holistic, and also bringing not only the absence of disease as WHO definition, but also the well-being of people. I think the psychosocial well-being and that dimension, I think, has always been something with me. And I was fortunate, I was Tunisian born, but grew up here in Switzerland, and being in Geneva, it's an international city. So from the beginning, I wanted to be a journalist, not even a doctor. And then, I said, okay, I will have to go through this job, do it well, learn the clinical practice. I spent 17 years in Geneva University Hospital, moving from internal wards to community wards. I work in prison with migrants. We developed also a global health division here in Geneva that were interacting with all the world. I was a scientific director of the Geneva Health Forum. That's still a very important conference here that brings together more than 1,000 people from all countries in the world. So I was very much interested to see not only what here at the center of discussion is happening, but also in the across the globe. So I came to know people from WHO, and
then you joined WHO. So yeah. What is then, let's say, just a few what is the thing that you can do at WHO but nowhere else?
I used to work a lot in emergency care, and I used to say the end result of my action I can immediately see. Sometimes it's life and death, it's resuscitation, it's immediate action. In public health and systems, it takes much more time, but you have also much more long-lasting impact potentially. So what I found fascinating with WHO is that we are elevating health as a core element of sustainable development. We are trying to convene people. We are trying to bring science and data and information about what are the trends. And we are trying to provide really solutions to member states through system change.
So it's fair to say that as a doctor, I treat patients. I'm very proud of that. But somebody told me that you guys try to treat societies. Is that a fair way to do it, say it, or?
Yes, I think. We are trying to address systems, societies, and also, understanding that health is a social construct. It's within an environment, so we need also to take into consideration the social determinants and climate change and all the major topic that we are trying to address. Impact health, and health is also a prerequisite for sustainable development. So it's a really
so basically trying to connect things at a let's say a meta level. Another thing I think I need some help to understand, because some systems are complex, but also your system is complex. So now you have the World Health Assembly. Can you explain it briefly? I understand that you have 194 members of WHO. So why is the World Health Assembly so important? And what is the relation between the World Health Assembly and what WHO do?
Okay, so we are first a UN agency, a specialized agency of the UN system, and our governing bodies are through our member state. It's a member state-driven organization. So the World Health Assembly is the moment where all those decisions are taken and where we report back, but also member states deliberate.
So who speaks at the World Health Assembly?
So we have first an executive board that are a subgroup, 34 member states that are preparing in January what will be finalized, endorsed, noted, and sometimes adopted as resolution or decision. So these member states are framing for every single session what are the key elements. Some of those items are global health items that we follow over the years and take a lot of time because it's never ending. And some new topics are of course brought up, as you have seen, I mean, today and these days after the pandemic and the COVID, all the discussion about pandemic preparedness is an important topic. But we have a set of topics that are brought to the attention, and this is where the organ of the assembly take decisions. So they are mainly member states, with the secretariat also reporting back. And
so they're sort of making or impacting the work plan for the coming year? Is that way? Now we just had visitors here from health ministers from Brazil and Egypt. So they were speaking there and putting the perspectives of their countries, and then you put it into your work.
They are shaping our work plan, what we call the General Program of Work of WHO. Now that it's a biennium plan, but has been extended until 2025 because of the pandemic and the lack of progress. So this is really where the member states are giving us the impulse, and we try to respond to that by developing also our work plan according to those directions. Yes.
Okay, let's try to shift gear a little bit. So the point of departure for this whole meeting today is this epidemic of fatty liver diseases affecting 10% of children and more than 30% of adults, are now leading cause of morbidity and mortality, liver cancer, liver transplant across the world. So what was your takeaway from the meeting today, where you met many of my colleagues, but also some of yours and some health ministers?
It was fascinating. The first thing is that it's an unorganized component of something that is extremely prevalent. It's a component of what we call the metabolic syndrome, and the expression through the drivers are obesity, hyperlipidemia, diabetes, of course aggravated by alcohol, and the expression is mainly cardiovascular event, plus the liver element of cirrhosis, and to some extent also liver cancer that's also growing. So the first thing is the recognition of this, and how we raise awareness about the interconnectedness.
How far do you think we are from global awareness? I think we talk about it all the time, liver doctors or in our communities. But is it over the radar level anywhere in the world, or?
Not entirely, otherwise we wouldn't be here.
Do you know? That's exactly. So do you discuss it internally, or have discussed it, or is this something we need to bring to the table? That's basically a responsibility.
I think it requires, we have similar discussion with, I would say, to make a parallel with the nephrology community and other communities that's a bit, we are not reflected there. It's the complication of a lot of those NCDs. But we don't see exactly how you highlighted this in your policies, in your document. And I think there was a need, as I mentioned earlier, to make the case first by showing in a simple term something that is quite complex and just highlighting their linkages, bringing the element of the data and the epidemiology and the trends that we are actually already witnessing, and then really addressing also the solution. And the solution are not individual scale, are public approaches that are how do we address fatty liver disease within the context of NCD prevention and control at large, or obesity acceleration plan as we discussed, and trying to really flag some solution that the countries can say, even in low income settings, I can do something. And you have had example from India or even from Egypt, that platform of delivery that have been used to really expand to include, I was in India last week, as I mentioned, an announcement of the government of 75 million of people under treatment for diabetes and hypertension, it will have an impact on liver disease as well.
So this approach where we try to gather everyone across the globe, because actually a patient is a patient, disease is more or less the same, makes sense also from your perspective. But then maybe go to, so from today, the vision is to end fatty liver disease as a global public health threat. And our mission is we want to have fatty liver disease recognized as a non-communicable disease and implemented in policies. So how do we actually get there to get it recognized as a non-communicable disease?
I think it's already there. The sense is that as we make the connection, I mean, as an internist, I would not like to slice also.
So it's not a formal thing where you decide at WHO now it's a non-communicable disease.
No, I think we discuss also the terminology and the nomenclature, and I think there is something there that could also contribute. The NASH or the NFLD.
Yeah, we worked for this. Now it will be steatotic liver diseases. Again, this effort that we see the evolvement, how do we actually integrate with knowledge we have and see these diseases as a spectrum. So I think that will also be helpful on several levels.
I think it will help because metabolic associated says something that is different from the kind of acronym that are used at the moment. But it's only one aspect. I think the other element that I wanted to stress is really how we use the existing platform of NCD, the guidelines to say, think about this as well when you are assessing whether the risk or the cardiovascular risk across those populations. You need to take into consideration that they might have a range of complications.
So that could be a way to go to say, of course, then you at least take a part of the patient, because of course patients with diabetes or overweight, they are very high risk. And that's also, I think, very painful for people like me to see the textbooks in endocrinology. You look for the eyes, you look for the kidney, you look for the heart, but the liver is nowhere to be found. No. So that's definitely.
But even in public health approaches, as clinicians, we see it through handbooks and guidelines that are from clinicians. But from a public health perspective, I mean, the program, like in India, is administered by community health workers. What is there for them if they have to detect those complications? Can they do something that is non-invasive, simple, and can be reproduced at scale to contribute to that? Yeah.
Can you say something very briefly of how is then the process from, let's say, we now see there is really an issue. It has been ignored. The consequence is significant. We actually have tools to do it, make it different. What is the roadmap then from that knowledge and then have it implemented in the beginning policies or priorities as WHO?
I think one aspect, as I mentioned, is data and how we use the burden data as an element. It could be through a policy brief and in styling that in the complication of NCDs, there is, as I said, a kind of continuum. And they all end at one outcome is mainly cardiovascular events, unfortunately, whatever it is. And trying to show from the data that those contributions are also not only unilateral, but are going both ways. People with fatty liver disease might be at increased risk of also developing diabetes.
So basically we need just to explain what we already know in the medical community or in the hepatology or in our ecosystem in a simple way. And
simple way and in a public health approach way and not a kind of clinically individual focus. And the same for the solution. What would be the element of diagnosis that could be done at a large scale? What are the options of treatment? And stressing that already a lot of the options, including the technical package that WHO is recommending, will have a benefit on liver. And I think some of the other community where we had, colleagues coming from the diabetes societies or from the cardiovascular society have already used this. How can they integrate their support and really align with WHO in some of the technical packages, in some of the guidance that is provided? This is actually where we collectively reinforce each other.
Amazing. I know you're very busy. You know you have the World Health Summit. Oh, one question. So we know this is just the beginning. We know it take last year, lots of years. Next year we will do the same again. Hopefully we have more stakeholders, more country representatives or member states, but we'd like to invite you. Will you be back next year?
Of course, and happy also to not only me and WHO, I think, but also I was very pleased to have member states, because at one point, whatever we do here in Geneva need to trickle down and be contextualized in countries and region. And the most important is to have those examples, having the Minister of Health of Egypt or representative from Brazil. Brazil will be the next country for the G20. So we have also opportunities to show that those countries are taking this seriously and are also showing ways and models that are also applied in their context. And this is the most important thing.
Thank you very much. Looking forward to see you again.
Thank you.